Dear colleagues, welcome to today's webinar on secondary mitral regurgitation, when to treat and when to repair. I am Jan van der Heijden. I am an intervention cardiologist in St. Jan Hospital in Bruges, the little Venice of the North in Belgium. I have Dr. Jerry Brown from the University of Leiden, thoracic surgeon. And on my right side I have Professor Roman Pfister from the University of Cologne from Germany. The aim of this webinar is to give you a better understanding of the treatment for patients suffering from advanced heart failure based on functional or secondary MR and reduced ejection fraction. Both surgical and percutaneous options will be discussed through clinical case presentations. This session is highly interactive and we strongly encourage you to actively participate by sending your questions, your comments at any time during the webinar through the chat. For the best learning experience, we would also invite you to participate in online assessment sessions in the form of MCQs that will be submitted during the presentation. Anything you need to know, just ask and we will provide tips and tricks for you for your daily clinical practice. And now I would like to hand over the word to Roman on my right side.
Thank you very much, dear ladies and gentlemen. I will present the first case for tonight. It is about a 74-year-old male patient. He has a long-standing history of congestive heart failure, currently in NYHA class 3, and he had a decompensation with hospital admission last August. And his underlying disease is a dilated cardiomyopathy with a moderately impaired left ventricular ejection fraction. The genesis is expected to be toxic from chronic alcohol abuses. He also has a coronary one-vessel disease which is without relevance and without need for revascularization at the moment. He also had a history of permanent atrial fibrillation with several PVEs during the last years. He has an ICD for secondary prevention after cardiac arrest, and he has some other comorbidities with moderate obstructive lung disease due to smoking. He has moderate chronic kidney disease, and he has, based on his alcohol abuses, liver cirrhosis child A. At the bottom you see his current medication with oral anticoagulation for his atrial fibrillation. He has diuretics, and he has heart failure treatment with ACE inhibitor, beta blocker, and spironolactone with, I think, pretty good doses. The ACE inhibitor couldn't be increased further due to low blood pressure. You also see a snapshot of his ECG. He is in atrial fibrillation again and well controlled, well rate controlled, and he has no evidence for a bundle branch block, so there is no indication for CRT at the moment. Here you see his echo results. On the left top you see a four-chamber view with double color image, and there is evidence for relevant mitral regurgitation. You also see some measures for the quantification of the mitral regurgitation. The bottom left is a two-dimensional vena contractor. You see at the top right arrow calculated by the PISA method, and you also see a vena contractor on two different planes on the right bottom. There are some additional echo results. You see the moderately decreased ejection fraction. You see a mildly dilated left ventricle with 61 millimeters and a preserved right ventricular function and dimension with a moderate tricuspid regurgitation. So we have a patient with chronic heart failure and severe secondary mitral regurgitation. And this distinction is very important when we talk about mitral regurgitation. There are two distinct diseases: the primary or organic form, which is a disease of the valve structure, and the secondary functional disease, which is usually a result of a ventricular or sometimes atrial disease, with two main pathomechanisms: the annular dilatation and the restrictive leaflet position. Both diseases have different diagnostic cutoffs, as you will see. Both diseases have different therapeutics and different prognosis, so we have to be pretty clear what we are talking about, and today it is about secondary mitral regurgitation. Of course, the next step is to be sure about the degree of severity, and quantification of regurgitant valvular disease is not that straightforward as for the stenotic diseases. You see there are several quantitative and qualitative parameters which we need to follow and to assess, and not all of the parameters can be assessed in the same patient due to technical reasons. I don't want to go through all the details. One point I think I want to highlight is some discrepancy between guideline recommendations regarding thresholds for severity. You see the European guidelines recommending an ERO-A, so an effective regurgitation orifice area of 20 square millimeters for the secondary mitral regurgitation. And on the bottom you see the American guidelines recommending a threshold of 0.3 square centimeters. So there are differences, and we will come to this later during the case presentation. So this brings me to the first question. When we think about treating secondary mitral regurgitation in heart failure patients, what would be the last step you think about in your therapeutic algorithm? Answer 1, ACE inhibitor and beta blocker. Answer 2, mitral valve repair or replacement, whether interventional or whether surgical, doesn't matter at this stage. Answer 3, cardiac resynchronization therapy, CRT. Answer 4, mineralocorticoid receptor antagonist. Or answer 5, angiotensin receptor neprilysin inhibitor, ARNI, or Entresto.
So please, ladies and gentlemen, give us your votes. While we are waiting for the results, Roman will continue his presentation.
Yeah, we always have to keep in mind when we are talking about secondary mitral regurgitation, we are talking usually about a patient with heart failure. And we have pretty good guidelines and we have pretty good treatment options for this disease. This is the treatment algorithm from the ESC guidelines 2016, showing several class 1 and class 2A therapeutic options with proven benefit on mortality and heart failure hospitalization. And before we think about treating the secondary MR, of course, we have to be sure that all the conservative or device options are fulfilled in our patient. And if we do this, we know from observational studies that we can improve mitral regurgitation in about 40% of these patients with this treatment. So
maybe I'll just give you the results. So 6% of the audience voted for answer number 1, 59%, so almost 60% for question number or answer number 2. Almost 20% for cardiac resynchronization therapy, 3% for answer 4, and 13% for answer 5. So it seems we are on the same level with the audience. Roman.
Excellent. So the evidence for heart failure treatment is pretty good, and this must be the first step, as I said, and then we can think about treating the secondary MR. And this is just the next question. If we now think about treating the mitral regurgitation with an interventional approach, what would be characteristics of the patient which would hint us towards the interventional approach? Answer 1, is it a high risk of cardiac surgery? Answer 2, the severity with an ROA of 0.21 square centimeters. Answer 3, a morphology of the valve with a dominant central regurgitation jet. Or answer 4, an advanced symptomatic right ventricular dysfunction. Or answer 5, a left bundle branch block without CRT therapy so far. So I think during the audience is voting, we will continue. And some of these answers we already addressed in the previous slides. Of course, CRT would be the first choice before thinking about the treatment of the mitral valve. Now, when we look in the guidelines again, what are the recommendations or what are the criteria for applying MetroClip in secondary mitral regurgitation? Then two important criteria are a high surgical risk or a severely depressed left ventricular ejection fraction, which of course is also associated with a high surgical risk. And we are also encouraged to use objective scores to quantify the surgical risk in our patients, for example, the Euro 2 score. And in our patient, this was 3.8% mortality, estimated mortality, which is not very high. But we also know that these scores can't cover all the important comorbidities. And in our patient, we have liver cirrhosis, which is not covered with this score, but has a strong impact on the surgical risk. So this would be one criteria, of course, pointing to an interventional approach. The second very important issue is, of course, the valve morphology, whether it is suitable for mitral clip therapy or not. These are the TOE results of our patient, and on the upper left you see that there is presumably an annular dilatation in combination with restrictive leaflets. You see a small coaptation defect within the PA2A segment, and this is also the origin of this massive regurgitant jet, as you can see in the right upper plane. And if you look at the three-dimensional echo on the right bottom, then the leaflets overall look very normal in their structure and mobility. So there are several suitability criteria published for mitral clip, and I show you here a table from the German Society of Cardiology classifying as optimal or suitable or unsuitable for mitral clip. And I don't want to go through all the details, but we can say that in our patient we have several good or optimal conditions for interventional mitral clip repair. We have a central pathology. We have no calcification in our leaflets. We have a large opening area of far beyond 5 square centimeters. We have mobile and long posterior leaflets with more than 10 millimeters. And we have a more or less normal leaflet strength and mobility. So this is, from the morphology point of view, I think a very good case for mitral clip therapy. So far, we didn't have any evidence supporting that treatment of secondary MR affects prognosis in our patients. And end of last year, the first two randomized controlled trials were published on this issue, comparing both optimal medical therapy with mitral clip treatment. The left panel, you see the Mitra FR study from France, and on the right you see the COAPT trial from the United States and Canada. And I showed you here the Kaplan-Meier curves for the primary endpoint, and on the left you see that there is no difference regarding death or hospitalization for heart failure in the French trial. And on the right you see during 24 months of follow-up a significant improvement in hospitalization rate for heart failure associated with the mitral clip therapy. So we have two similar designed trials with diverging results. And the question, of course, rises, how can that be? And to answer this, we have to go into some details of the trial designs and also the trial procedural results. You can see that the COAPT trial was much larger than the Mitra FR, so the overall had more statistical power to detect any differences. The first important difference, as you see here in the first line, is the inclusion criteria regarding MR severity. And as I already mentioned, there are differences between European and American guidelines, and the Mitra FR study followed the European guidelines, the COAPT trial followed the American guidelines. And as a result, we had much more severe MR in the COAPT trial compared to the Mitra FR trial. This is, of course, one important issue, because the more severe the regurgitation, the more benefit could be expected from its treatment. The second very important difference is the left ventricular volume, because in COAPT there was people or patients with dilated left ventricles more than 70 millimeters and systolic were excluded. And the idea was that these are such advanced patients which might not benefit from any treatment overall. And as a result, you see that the mean or the average left ventricular volumes were much larger in the Mitra FR study compared to the COAPT study. A third very important point is the validation of optimal medical therapy before the study. And this was done in the French trial by the local investigators, and this was challenged, as I have to say, in the COAPT trial by a central committee. And so this, in combination with changes during the trial follow-up, where we learned from COAPT that there were only minimal changes in heart failure therapy, and where we have no valid data from the mitral FR trial, suggests that there could be changes, there could be improvements of heart failure treatment in the French trial, which of course could overlay the effect of the valve repair. These are the design differences, and on the last 3 lines you see the differences in efficacy and safety of the procedure, and there are also substantial differences. You see the success, so the implantation of a clip with a reduction of the MR to grade 2 or lower was significantly better in COAPT compared to mitral FR. So this is the failures. The failure is 5% versus 9% in the 2 trials. Similar for the safety, so for the procedural complications, these are almost 2-fold higher in the French trial compared to the American trial. And the durability of the repair, which is also a quality criteria, was also substantially better in the COAPT trial compared to the mitral FR trial. And these last 3 procedural aspects might be the consequence of more expertise in the American interventionalists compared to the French interventionalists, where the mitral clip had no reimbursement at the time of the trial performance, so there was very few experience in the interventionalists. So I think there are several very plausible differences between these trials which can explain the differences in outcome we have observed. So a long story, and we have to come back to the initial question, which characteristics would favor an interventional repair of the valve?
So the results of all you watching is 40% high risk of cardiac surgery. Then we have like 23% for answer number 2 and 3, 30% for answer 4, and 3% for answer 5.
Yeah, I think this is pretty obvious. High surgical risk is pointing to interventional approach, and the morphology is also straightforward. And I think 20% were for the second question. And this is, of course, an ongoing matter of debate, where we will define our cutoffs for the treatment of functional mitral regurgitation. What we learned so far from the first results of both trials is that an ERO of 0.3, of course, as applied in the COAPT trial, is associated with a substantial improvement in outcome. Yeah, so in our case, in the end, we decided for an interventional treatment using the mitral clip. You see the procedural echoes on the upper left. This is the grasping step where you see the arms here beyond the leaflets. You see the grippers coming down at this moment and the arms closing. This is the final 3-dimensional result, looking from the left atrium on the valve, where we had 2 clips in the central position, and this is the Doppler result with only trace residual mitral regurgitation in the end. And I want to conclude. The secondary mitral regurgitation is obviously a disease of the left ventricle, so we have to be sure that we had an optimal treatment of this heart failure according to current guidelines, including drugs and then also including devices like CRT, before we think about the treatment of the regurgitant valve. We have now the first evidence, and this is, I think, a landmark trial, COAPT, that specifically addressed treatment for secondary mitral regurgitation can improve prognosis of the patients and can improve or can attenuate the progression of the disease. And yeah, this is game-changing and a paradigm shift. And the important issues when we think about interventional treatment of secondary MR are, of course, making sure the maximum and optimal tolerated guideline-directed heart failure therapy, Patient morbidity is important to judge about the surgical risk, but also to judge about the potential symptomatic and prognostic benefit of an interventional approach. Of course, the valve morphology is very important, particularly for the interventional approach, because we have at least only one established technique so far to treat this disease. And what we learned from COAPT and MITRA-FR is that the severity or the stage of left ventricular remodeling reflected as left ventricular dimension or volume is very important also for the potential benefit of treatment.
Okay, thank you, Roman. We have a lot of questions coming in, ladies and gentlemen. Thank you for that. Quickly, some questions for you. I will ask you to answer this one briefly. Euroscore or CTC? What would you use or recommend?
We are in Europe, so usually we take the Euroscore.
Good answer. Then a more difficult one. How to calculate the ERO when there are more than one jet in functional MR? Maybe I can help you with that. I think in a lot of patients with functional MR, I think there is only one jet, and it's a question of really having your TU probe moving around to identify the biggest ERO. So I think you should measure the biggest ERO. And then before we go to the second presentation, let's see if there is one more question we can answer. This is maybe also something you want to address, Roman. Should we wait to treat patients with MitraClip until we see a severe MR, or are we too late by then?
Well, this is a tricky question because, of course, we need a severe disease to treat it, but we don't have to wait till it's too late. So we should be early in severity. So it must be severe, but the MR must be severe and not the remodeling process of the left ventricle. I would phrase like that.
This would be challenging for all of us to identify those patients at the right time. So we are ready for the second presentation.